The next case I'm going to show you has finding the hidden key. It's a case where you also have to look very closely to detect the problem. This is a patient who came to us with the symptoms of dyspnea, which were very difficult to actually interpret. When she sat across from you, you had the impression that she's doing very well, and that her symptoms are maybe not really symptoms of dyspnea, but maybe more of some stress or anxiety. But she was she went from one doctor to the other, and a number of different echo exams were actually performed on her, and nobody really found a reason for dyspnea. What we did first is we put her on a treadmill test, and we saw that her exercise capacity was rather poor. And so we did believe that she really had dyspnea, and we repeated an echocardiogram in her. And I'm going to show you the different image loops, and I want you to closely take a look at the echocardiogram and solve this mystery and answer the question if you think that there is some cardiac problem. Parasternal long axis view. This is the short axis view. Left ventricular function. Okay, take a close look at left ventricular function. Regional wall motion abnormalities. Okay, we're just calculating the size of the atrium. The septum had a normal thickness. This is her four-chamber view. Okay. This is left atrium, right atrium. Okay. Well, what are the potential reasons that you can have that can cause dyspnea? Systolic dysfunction, cardiomyopathy, similar to the patient we saw previously. Or maybe the patient has diastolic dysfunction. This is her post-wave Doppler signal across the mitral valve. E wave, A wave. So what kind of pattern do you think this is? The E wave and the A wave. The A wave is taller than the E wave. In other words, what we have here is a relaxation pattern or disturbed relaxation. That usually means that her filling pressure is not very high. It's probably borderline or normal, but that does not really explain her dyspnea, or does it? Okay. Does she have a valvular problem? Do you see mitral regurgitation, which could explain her dyspnea? Well, there is mitral regurgitation, but not very much. It's very trivial, actually. And the mitral valve also looks very normal. So this cannot be the cause. Actually, you would not really have to turn on the color to exclude mitral regurgitation as the cause of dyspnea, simply because her left ventricle is normal in size. So that kind of excludes that she has volume overload. But still, okay. This is now her subcostal view. There's no pericardial effusion. What else would you want to see maybe? The aortic valve. Okay, that was normal as well. We had normal velocity across the aortic valve. Oops, okay. So, pulmonary hypertension, could that be the cause? Well, the problem was that we could not really get a very good signal with her. So, we could not measure the pulmonary pressure. So, we're kind of lost with respect to how high her pulmonary pressure actually is. But let me ask you, what do you think is her problem? Okay. Can the echo explain dyspnea? I might be fooling you. I might show you a normal echocardiogram and actually she has some form of pulmonary disorder or chronic obstructive lung disease. Okay, so the answer, 28% say the echo is completely normal. You can't find the clue in the echo. 17% do say that she has cardiomyopathy. 6% say yes, she has ischemia. Aha, interesting. 50% say yes, there's something else. Okay. Just a little clue. If I ask the question, is there something else? This is usually the right answer because I'm trying to hide something. And this is exactly the reason that I'm showing you this case, because there is something hidden in this echocardiogram. Let me just go through the echoes once more. This is the parasternal long axis view, and I want you to take a very close look at the motion of the septum. Okay? The motion of the septum is not completely normal. This can probably be seen best here in a short axis view. I will turn down the speed, and I want you to take a look here at the septum at the time when contraction actually begins and during systole. So, okay, this is now a systolic frame. And here during the systolic frame, you can see that there is very discrete flattening of the interventricular septum. Okay, so some of you probably thought that this was a regional wall motion abnormality. So this is probably the explanation why some of you thought that she has ischemic cardiomyopathy or ischemia. But actually, this is just simple, plain old abnormal septal flattening, which occurs in the setting of right ventricular pressure overload. So if you see this, it's very, very suspicious of pulmonary hypertension. I'll show you the four-chamber view again, and if you, again, just take a look at the septum. You can see a little motion of the septum during systole. Now, this is certainly not a very severe form of abnormal septal motion, but it is indicative of pulmonary hypertension. And it's very, very valuable to use this sign if you cannot measure pulmonary pressure otherwise. Now, there's another sign that can help you to determine if the patient really has pulmonary hypertension in the absence of TR signal. This is the PR velocity, the velocity across the pulmonic valve. Here you can measure the so-called pulmonary valve acceleration time. So what you do here is you take, let me just find, okay, the calipers. You take the time interval from the beginning of the signal, which is here, until the peak of the signal. And we have a time interval here which is 76 milliseconds. Normally you have 120, 130, 140. This would be a normal pulmonary valve acceleration time. In this case, it's much, much shorter, and this is indicative also of pulmonary pressure. Now, I didn't really give you the full story. I do want to show you the TR signal that we did get, which was not very nice, but we at least got a signal which is at least 6.3 meters in velocity. So I'm pretty sure that the velocity probably is even higher, but we can be certain it's at least 3.6 meters per second. So we have a gradient of 53 millimeters mercury. If we add the right atrial pressure to this, we're probably somewhere in the range of 60 millimeters mercury. Definitely she has pulmonary hypertension. So what did we learn from this case? That the patient has pulmonary hypertension. And we also found a reason for pulmonary hypertension. This is pulmonary angiography of this patient, and we see that she has chronic thromboembolic pulmonary hypertension. In other words, she had recurrent pulmonary embolism, which occluded the pulmonary arteries. You can see that the vascular bed is missing here. There's an abrupt seizure of contrast here in the lower pulmonary artery. Okay, so what should you remember? Pulmonary hypertension is can also be noted in the absence of a TR signal if you have flattening of the interventricular septum. This is a severe form of flattening. She certainly had a much less severe form, but look for this trivial forms of septal flattening as well. And also look at the pulmonary valve acceleration time.